one, a two, a one, two. Good morning, everyone. My name is Albert Terrillion. I'm the Deputy Director for Evaluation and Research for Community Anti-Drug Coalitions of America. I'm going to wrap my presentation Hamilton style because we only have 7 minutes. I'm not going to do that. It's been a great privilege to be here for the last day and a half and to listen to all the great expertise and the knowledge and wisdom that's there, and I'm going to frame my presentation to begin it around something that was said yesterday by a presenter who said, I am programs. Well, my juxtaposition is I am communities. Originally, if you can tell, I am from New Orleans, Louisiana. Did a lot of work in the parishes around, including work in Calcasieu, St. Charles, St. John's, Orleans, Washington parishes. And if you look at the county health rankings, you know that we had our work cut out for us. We did that for about 15 years with support of state public health. And we were able to get to some levels of sustainability and toward longevity in terms of our successes through partnerships and through relationships. That said, it brings me to where I am right now, working with the Anti-Drug Coalitions of America, founded in '92 as a recommendation from the President's Drug Advisory Council. There's some more information up there. We have about 5,000 different coalitions that are established, some who are drug-free communities grantees and some that have been able to continue their work through other forms of funding. The important thing is that the work starts from partnerships and relationships. We do give these coalitions 3 different periods of trainings in their first year, and then we give them support throughout the year and throughout all their years with technical assistance and trainings, twice-a-year meetings, and a lot of support overall. The important thing for us is that we're trying to sustain and maintain the priority of partnerships and relationships and those strategies that work from the ground up. Because when I started my work in Louisiana, it was in the 80s, and I am dating myself, but something that really influenced me came from this book called Megatrends. Anybody remember that book? Anybody? John Nesbitt. The key message in Megatrends was trends are from the ground up. Fads are from the top down. Trends are from the ground up, fads are from the top down. That said, it was very important for me in my life to work from the ground up with these communities and to continue that work right now to the day with CADCA. That said, the framework for community change is in front of you right now. This was referenced yesterday by our own Sue Thaw, is a chance for us to work through several steps with those coalitions to make sure, again, that they are able to affect that change in prevention work from the ground up. And you'll see those various steps there. What I want to be very careful with, especially being from New Orleans, is this is not a who you know and by the seat of your pants kind of culture. There are assessments and there is evaluation, and we're using our data. I will not show you the data because I'm afraid I don't have time to do that. We only have, 5 minutes left? Oh man, 3 minutes, okay. That said, what I want to do with the rest of my time is talk about evidence-based and talk about the different types of how this is used within the community in my experience, including with coalitions. And what I want to do is try something real quick here on differentiating the types of evidence-based. What I'm going to do is call one type of evidence-based low agency, and I'm going to call the other one high agency. High agency means a lot of contact, a lot of face time, a lot of touch with different community members, a lot of back and forth. This also means that there is a cost dynamic there. Some programs do cost money, and there is some payment that's necessary for that. Low agency generally tends to work with, and these programs, you'll see them on the Administration for Community Living, and there are some other ones there as well. Low agency are those that work within more political environs, those that affect more population change. And you can see them with the Community Guide, the Cochrane Collaborative, and the Campbell Collaborative. Now, I want to be very clear that when we talk about using the evidence base in communities, we are asked to address 3 questions. What do communities need based on my experience? How does that align with current evidence-based practice? And how do we infuse evidence-base into a community? In working in Louisiana, we use the Community Guide and we use evidence-based on that level. Now, I want to be very clear that when we look and work with coalitions from the CADCA perspective, a lot of those are DFC, and those low agency ones which may work toward policy, we can't speak to that legislative piece because there's federal funding there. but we can work to help them with policy with businesses. For example, in the community guide, we have dram shop liability. We have maintaining limits on hours of sale for alcohol, taxing of alcohol. Now that's legislative. Let's be careful with that. But for tobacco, there's quit lines. There are other evidence-based practices within the community guide that can be used, and we have used those. In Louisiana, we used the blood alcohol level of 0.08% before we even got the legislation teaching that within the communities within which I was working. Now that said, for the higher agency and using those in communities, it's a lot trickier. It's a lot more sensitive. Yesterday, the point came up about communities that there's a certain instability to them, that there's a lack of continuity. I would also posit that there's real diversity, there's that real chance to affect real change, and there's a real vulnerability. And that we have to be very careful about what we drop into these communities that doesn't come from within, from these communities. The second thing is, what I'd like to mention is, that we got yesterday in talking about evidence-based into a real industry, it seems. This evolution of something which is come about in response to evidence-based within healthcare. Healthcare has a lot of money. It was funny to me yesterday, the CMS guy said, healthcare's got a lot of money. Well, CMS is giving them all the money. That's why they have a lot of money. But the point is that what we have here is a tremendous industry, and there's an industry being created from the program or from the, dare say it, a different side, which is trying to compete and trying to show the value and trying to speak to the cost, therefore they can get that reimbursement. But we have to be careful with that because those communities with whom we're working don't have a lot of resources. And it strikes me as a little bit odd that something that makes you healthy you'd have to pay for. I know we have pills and such, but some of these interventions are a little different. The last thing I want to speak to is the role of academia. I worked for Tulane University when I was doing a lot of this work in Louisiana. And what we discovered as we were working with these communities is that we couldn't help but be changed as we were doing that work. We couldn't drop in parachutes in these communities and tell them what was happening and what they were doing wrong. We actually had to learn to bring the people back into our offices, and eventually we hired them and eventually made them a part of the decision-making process. It's very important to remember that real change does happen from that level, from the ground up and from communities, and by listening to them and listening to the people that are living there, we can pay attention to the social determinants, be very mindful of the needs that are there, and work around those prevention steps that really do improve our health. Thank you very much.